welcome everybody to today's session. We welcome Dr. Christine Drummond and Kate Swetnam to present. Unfortunately, I apologise, but Peter Allcroft is not able to host today because he's on holidays in Whyalla. He is here, but we're having troubles with his audio. So thank you very much, Dr. Drummond and Kate Swetnam, for presenting today. It is very much our first look at voluntary assisted dying and a first conversation. So I'll hand over to you.
Thank you. And thank you, Kate, for agreeing to be part of this as well. And thank you, everybody, for asking for our input into this. I don't purport to be an expert in this field. I'm someone like everybody else who is trying to learn as much as I can at the moment about something that's very, very complex. And as Nicole said, this is a first conversation. As such, I don't think we, within an hour, have time to delve into all the minutiae of the law or local site implementation, although we welcome, questions and comments that we might end up taking on notice. This is going to be a broad conversation today as a starting point to looking at what things we need to consider when we're looking at aspects of the implementation of VAD in our state. So I think the first thing we need to do is look at where VAD is around the world and reassure those of you who are still incredibly uncomfortable about this that we're not the only people in the world doing this. Next slide, please. So voluntary assisted dying is known by a number of terms around the world: euthanasia, death with dignity, physician-assisted suicide, and medical assistance in dying. And as you can see, there are various places around the world that incorporate this clinical activity into normal activity. Several states in the US, Canada started their MAID activity in 2016, and there's consideration of broadening the scope of that now. New Zealand held a referendum in 2020 that was very highly endorsed. The activity was very highly endorsed. So our neighbouring country. And then on the next slide, if we look at VAD in Australia, in the incidence of deaths by euthanasia, I'll call it euthanasia for the purpose of this slide, has been relatively stable in countries where once it's gotten to a certain point. So in the first couple of years, until people are confident with the systems, deaths have increased, the incidence has increased a little bit. But you can see in Oregon, which is a place that we all think about when we think about that being around for a considerable time, it's still a small proportion of all deaths. Canada's a higher proportion, and I expect that the proportion of deaths may increase to the same as in the Benelux countries, being the Netherlands, Luxembourg and Belgium, as the scope of the activity increases. So at this stage, eligibility in Canada is based on prognosis as well as suffering. But there's a push or a move to consider suffering only, not necessarily only proximity to death. And you can see the difference between the 2% in Canada and 4.6% of deaths in the Benelux nations, where proximity to death is not one of the eligibility criteria. So, there's potential, depending on the scope, for the number of deaths related to this to increase. This is not what our legislation relates to, though. Next slide, please. So if we're thinking about Australia, next slide. You can see that we all know that Victoria enacted their bill in June 2019 after about an 18-month implementation period. Western Australia have only just enacted theirs in July this year as well. So once again, this sort of 18-month implementation period seems to be the amount of time needed to get all the processes in place to turn legislation into activity. The Tasmanian Bill was passed in April 2021, so that's this year as well. And there's an expectation again that is they're going to need 18 months to get things together. Queensland have passed a bill earlier this month. And as you would be aware, our bill was passed in the South Australian Parliament in June this year. And of all of the bills, it's most closely based on the Victorian Bill. Next slide, please. So let's talk a little bit about what our bill says. It's considered a fairly conservative bill in that it has a lot of safeguards around it. In fact, it has a couple more safeguards than even the Victorian Bill has, in that it has an option built into it for individual and institutional conscientious objection, which the Victorian Bill, especially the institutional objections, does not include. Our bill is very clearly distinguishes voluntary assisted dying from palliative care, suicide, and criminal activity. And they're really important underlying features of the bill. The essential elements of people requesting voluntary assisted dying is that they must be over 18 years of age, they must have been a resident of South Australia for over 12 months, and they must have a life-limiting illness with a prognosis that's likely to be less than 6 months or less than 12 months if their primary condition is a neurodegenerative one. Our bill is very specific that if a person has a mental illness or disability diagnosis only, these diagnoses are not enough on their own for a request for voluntary assisted dying to be placed. A person must make a request on 3 separate occasions. Initially, health professionals, doctors in particular, cannot raise the topic. The request or the raising of the topic must come from the person themselves. The person must have decision-making capacity. There must be no coercion in the request. And at one point in the process, the person must be able to write a written declaration once they've been assessed as eligible. So what this shows is that it's not a whim, it's something that's a pervasive request that's very specific in the law. The practitioners involved are 2 specifically trained specialist doctors making independent assessments. One is called the coordinating specialist and the other one is the consulting specialist. Their duty is to inform the patients of all options for care, ensuring that the patients, people who are requesting VAD, understand their illness and understand all options for care that are available to them, including palliative care. They must ensure, as part of their assessment, that there is a complete lack of coercion. Then they must ensure that the person meets all the criteria in terms of the illness itself. And once they are convinced of this, and obviously the practitioners must also be completely independent from the person and not be seen to be influencing either the decision or the timing of the decision. In other words, if you are in any way to benefit from the person accessing VAD, you cannot be one of these doctors. If you're a family member or you may benefit from the person's estate, for example, you may not be one of these doctors. So once the criteria for VAD are seen to have been met, then the coordinating practitioner applies for a permit to prescribe the substance for the patient to self-administer. There is an opportunity for physician-administered substance, but it is anticipated that the large majority of people, and the intention is that the large majority of people administer the substance themselves. So the method of voluntary assisted dying involves the prescription of a lethal medication for self-administration by the patient. As I said, that a doctor can request a permit to administer if the patient is unable to self-administer, but there are a number of really specific criteria under which that can happen. And there must always be a nominated contact person whose legal responsibility is to return unused substance if the person has died prior to using it or they change their minds, that it is their job within a prescribed time to return that substance to the dispensing pharmacy. The death of a person with a permit in South Australia is to be notified to the coroner. And this is regardless of whether the person used the substance or they didn't. So the fact that there was a permit in place means that the coroner needs to be notified. The underlying medical condition that led to the person requesting a permit or requesting assessment for eligibility needs to be stated in the paperwork after the death. So there will be documentation about the fact that they had the permit, whether or not the substance was used, and what the underlying condition was. There is provision within our legislation too for the South Australian Civil and Administrative Tribunal to review any decisions where there might be discrepancy between what different parties in the application process may think. So if, for example, a doctor, one of the coordinators, say one of the specialists involved, believes the person doesn't have decision-making capacity and the family or the person do think they have decision-making capacity, there is a right to review. And during that review process, the entire application process comes to a standstill until there's a decision made. I think the other thing that's really important in the legislation is that there is a voluntary assisted dying review board that will be developed, and they have oversight of every step of the process and the opportunity to review whether or not processes are being followed correctly, to keep records and to make sure that the paperwork within the process is all correctly completed. So the reason I'm focusing a little bit on this report, this is a report that Victoria put out every 6 months. They've been doing that since they started they've implemented their voluntary assisted dying bill. And the last report's only recently come out. And I just wanted to pick out some critical aspects of the Victorian situation because it may relate to what we're doing here in South Australia. It gives us an idea of some of the activity and some of the structures they have in place. So in Victoria, for those who don't know, there are 2 statewide services related to voluntary assisted dying. One is that they have a care navigator service, where across the state they have 8 care coordinators who support applicants and the providers of voluntary assisted dying as required. So it's almost as if they are the gateway to activity. They don't have to be. In other words, if I wanted to place a request, I could go and see a specialist who was registered, who'd done the training. I wouldn't need to go through a care coordinator. But a lot of the feedback they've had in Victoria is that these positions are really highly valued by everybody involved. The applicants and the providers have found that very, very useful. And that number of care coordinators has increased over time. They also have a statewide pharmacy service where they have, and this is based at the Alfred in Melbourne, so it's very, very central in the city. They have 7 full-time pharmacists and 1 admin officer. And it is their job to dispense the substances, dispose of any unused medications, and in doing so, they travel to see applicants wherever the applicants are, whether that be a rural, regional or metropolitan. And as you can see, almost 40% of the dispensing happened in regional and rural areas. They work 7 days a week, and their role is to dispense medication, to educate, to make sure that the applicants know how to safely store the medication, which is kept in a locked box of a specified nature, and to ensure that the contact person whose role it is to return the medication is completely aware of their responsibilities. So some of the feedback from the around the pharmacy service has also been highly positive, with people making comments like, well, my family could be around on a Sunday afternoon and the pharmacist came out to see me on a Sunday afternoon, which is a pretty incredible service, I think, very much appreciated. Over the last 2 years, the sort of demographic details about the applicants in Victoria has stayed very stable. The numbers may not have been stable, but the demographics of the kinds of people that are asking to access voluntary assisted dying has stayed fairly stable. Just over half are male. There have been a range of years from 18 to 101, but the average age is 72. The large majority of people have been born in Australia, and the Aboriginal and Torres Strait Islander population are represented at the same percentage as they would be in the general community. Only 2% of the applicants actually required an interpreter, which surprised me. Over 60% of applicants had senior secondary or above education level. And I'm not sure how that relates to the community as a whole, but given that 40% of dispensing happened in the rural and regional areas, it may be that we've got some selection bias towards people who have high education levels. Hard to tell. The large majority of people lived in a private residence, many in the metro area, and only 10% lived in a long-term care or assisted care facility, which may make people feel a little more comfortable that this is not about people in nursing homes necessarily requesting this with coercion. So the number in aged care facilities is relatively small. Interestingly, 83% of people had a malignant diagnosis. So as I said, these are very stable demographics over a 2-year period. There's been an increase in the last 6 months in the number of doctors being active in what they call the portal in Victoria. So a lot of the administrative side of this process happens on an IT platform. It necessarily has to make it practical. And there's been a significant increase in the number of doctors, but they're still reporting that the number of doctors are highly inadequate. And reports from individuals involved, this is not in the actual formal report, is that a lot of the doctors who had been involved in this activity up to the last 6 months ago anyway, were getting quite exhausted because of the number of requests that so few doctors were getting and the amount of work that each request was taking, the amount of coordinating, the amount of travel, and it was exhausting the few who were prepared to, be up front and be involved in this. So it's very welcome that the numbers are increasing. So in the metro area in Victoria, there are 161 doctors who are involved, and in the regional and rural areas, there are 92. Interestingly, the majority in both areas, particularly rurally, of course, are GPs. So this is outside, presumably, outside the public system. Although in regional and rural areas, if the activity is happening in the hospital setting, it is the GPs that support those hospitals. So it's hard to pick apart how much of this is public activity and how much of this is private activity. Interestingly, in Melbourne, only one palliative care doctor was active in the portal over that previous 6 months. 17% of the doctors were oncologists in the metro area, and 19% were what's called other specialties. And when you drill down in the report to what those other specialties are, it's really interesting because they've got things like general surgeons, hematologists, which is understandable, rehabilitation specialists, acupuncture specialists, clinical geneticists, clinical pharmacologists, some specialties where you might wonder about their expertise around particular conditions. So that was of interest to me, given that that's almost 20% of the doctors that are involved are perhaps not involved on a daily basis with patients who are at end of life. In the rural and regional areas in Victoria, there's slightly higher representation of palliative care doctors, but as you can see, there are only 4. This was interesting data for me too. So one of the things they found in Victoria is that it's not just the coordinating and consulting specialists, the 2 specialists involved in voluntary assisted dying directly, but it's other specialty areas that have had an increase in referrals to them. So for example, there's been a 47% increase in referrals to a specialist of some sort for assessment of decision-making capacity when a person has come to request voluntary assisted dying. So I wonder if that had to do with the coordinating or consulting specialists wanting to make absolutely sure that people are not making requests because they're depressed, or wanting to make sure that because a large number of these people are older people, that there's no cognitive impairment affecting their decision-making capacity. So in some ways, this is a very good thing, but it speaks to the resources needed to ensure that we do this properly. There was also a 51% increase in referrals for assessment of prognosis in those patients presenting with neurodegenerative disorders. So you can see that it's quite resource intensive. At the end of the report, it talked about compliance, and they do that every 6 months. And when you look back, compliance with all the processes in the legislation in Victoria has been really, really good. The times where where there have been issues have been, for want of a better term, not of such great public interest. So for example, there was one occasion where the contact person didn't return the unused medication within the 15 days that was specified. It was a couple of days late. And I don't know, the report doesn't allude to whether it was because that person lived far out in a rural area and couldn't get back to the Alfred to return the medication in a timely manner or what, but the medication was returned and the process was completed properly. So there was another situation where one of the specialist doctors involved didn't have the 5 years experience as a specialist that was required for them to be a consulting, one of the consulting practitioners. The other person thought they had it, but they actually didn't. It didn't, looking at the criteria for the patient, they were still eligible for voluntary assisted dying. There'd just been this miscommunication between the 2 doctors about one of the doctors' eligibility. So they weren't, the errors that have happened with process have not been of great public interest, if that makes any sense. So they haven't been of any concern. So in the first 2 years in Victoria, there have been 836 first assessments, which, is around about, 400 a year. Only 29 of those were assessed as ineligible, and we're not given reasons as to why. It may be that they weren't residents of the state for long enough. It may be that their condition was considered to have a prognosis longer than the requirements for voluntary assisted dying. We're not given that depth of information, but it's a very small number given the large number of assessments that had occurred. So these are first assessments with the coordinating specialist, the first specialist, and then people go on to have an assessment by the second specialist, which is called the consulting assessment. And over that 2-year period, Of the 836, 700 continued on to have their consulting assessment. So we're already seeing a drop-off of 136. And of those 700, another 12 were found to be ineligible. So all of a sudden, we've got about 40 people, 40 assessments that have been found ineligible. Now, that doesn't mean that the people couldn't go back and be reassessed by somebody else, but this is the data we've been given. Now, of those 700, 524 ended up receiving permits for self-administration. And of that 524, 413 had medications dispensed to them. So over 100 had a permit to get the medication, but didn't actually get the medication, didn't go and pick it up. Reasons for that? I don't know. Could be any number of reasons. But of the 413 who did have the medication dispensed to them, 73 were practitioner administered, and 342 of people died prior to use of their medication or withdrew from the process. So large numbers. If you have a look at the 836 first assessments, of that 342 died before either they withdrew from the process or died prior to use of the medication. So what that tells me is there's a lot of process involved, a lot of activity, but a lot of dropout along the way to ensure that people have a choice, but also that systems around them are tight in making, them enact that choice. 58% of the deaths were self-administered. 10% in Victoria were practitioner administered. And as I said, about 32% died without using the substance in any way. And over the 2-year period, this was in the last 6 months, so over the 2-year period, it's about 41% of people who accessed this didn't actually use it. I actually wanted to know what was the data around whether the deaths were happening at home or in hospital, because we know from overseas settings, particularly in Canada, that the large majority of deaths from voluntary assisted dying happen in people's own homes. And I had received some information earlier in the year from people involved, this is informal information from people involved in Victoria, that said there's considerable activity in the hospital setting, which is different to some of the overseas data that we've seen. At this stage, Victoria are not providing publicly available data on whether these deaths are happening in home or hospital, or whether, if they're in a healthcare setting, it's a private or a public healthcare setting. And I think these things for SA Health will be important data to gather for us to be able to know how we implement and manage resource around this, what that actually means. The activity in Victoria has been slowly growing over the 2-year period. And in the last report, the chair of the board, who's been on the review board the entire time, she has only just now retired, states that she has no doubt that we will continue to see an increase in the number of Victorians who consider voluntary assisted dying among their options for end-of-life care, who will want to pursue this option and have their permits, whether or not they pursue the actual activity at the end. So they're expecting an increase in resource required for this, an increase in the number of requests. Next slide, please. And the report also included some feedback from practitioners involved. And as I said before, they reported that a significant time and effort was involved for both the coordinating and consulting practitioners with each application. So my interest, I guess, in that was that how do you fund that in a public or a private setting, where does the funding for the resource come from? And in the implementation, this is going to be really important. They were saying this was especially important for the rural and regional practitioners who sometimes had really large geographical areas that they were looking after, and tossing up between, do I need to travel out to see somebody because it needs to happen face to face, or do I ask a really unwell person to travel to me for this? And there may be an expense associated with that as well, especially if they have to take an ambulance. The practitioners also fed back that the way the portal worked was really important to them, that it needed to be simple to navigate and that it needed to incorporate guidance about application requirements. It needed to really guide them through every step of the paperwork process. And there was some conversation about the fact that telehealth isn't allowed in this was problematic, especially for the rural remote regions. But there is intersection with the criminal code, so that it needs to be face-to-face activity. Thank you. So I was led to understand from the Victorian, a member of the Victorian board, that there were two services within Victoria that are considered to have very good models of implementation. Epworth Healthcare is the largest not-for-profit private health service in Victoria, and it's very easy to find information about their voluntary assisted dying service on the internet. So if any of you want to look it up, it's a very fancy, I'll show you, let me just show you the cover of this. It talks a lot about what they as a service have done. They've used a very values-based model. So they've gone to looking at what are the values of their health service and what are the values of their community. They've employed their own VAD coordinator so that every request that is received through Epworth Health is managed initially through the VAD coordinator. They very openly acknowledge and consider a conscientious objection. So they've surveyed their staff and they know which staff are happy to be part of this activity and which ones would have an objection. They've set up what's called a conversation pathway, where they know exactly what they need to say to people, how they have conversations, who's next in the conversation, what are the elements of education that people need. And they've set up a brochure that is useful for both the healthcare staff and people asking about voluntary assisted dying. They collaborate very strongly and closely with the palliative care service, and they maintain a database of all the activity that they are involved with. So they've really been considered a best practice model. And the other best practice model in Victoria that I hadn't had a chance to look into deeply is the Royal Women's Hospital in Melbourne. So that's a public hospital, and their implementation is known to be of a high standard as well. So from some of this, I picked out some of the big questions and learnings for South Australia from Victoria is what I focused on. And as I said before, we're not at a point yet where we can talk about the minutiae of how we're going to manage medications that people might bring onto an individual ward, for example. These are big picture considerations for the time being. And as we get further and further into this, the detail will become apparent and we'll be able to work to that. So one of the things that struck me was Victoria has a much larger population than South Australia, also situated over a much smaller geography. So when they're telling us they're struggling for the number of doctors required to participate in voluntary assisted dying, and part of the issue is access for regional and rural areas, this is an even bigger issue for South Australia. So how will we ensure practitioner numbers for increasing requests over years? That's the other thing that Victoria has struggled with. Considering that our population, yes, smaller, but we have a very an older population. So an older population spread out over a much larger area. So there are going to be challenges to equity of access across South Australia, particularly if we look at models of implementation that mean, for example, that the only place that the medication's kept is in a central pharmacy in the city. So how, you know, Kate and I were talking, how does somebody on Eyre Peninsula have equity of access to medication that's only kept in the middle of Adelaide? My other thought was that South Australia has a very large faith-based private health system. And I wondered whether this might affect the site of activity of voluntary assisted dying, particularly in the central part of Adelaide, which is where many of the referrals for private health go. The private health services are there. And with a faith-based health organisation, they are able to have a conscientious objection to this activity. So I'm not really sure what that means for us yet. We're going to have to consider that in implementation. I've already alluded to the specialty areas of the doctors involved in one of the earlier slides, where I said that there was that 20 or 19% of others. And I wondered whether we needed to consider that a little bit more closely, because looking at that long list that they had, it wasn't really clear to me how some of those practitioners could be seen to have enough experience or expertise in end of life. The other thing I noted from the Victorian training for the practitioners is that it really focuses on the legal and aspects of the process and the logistics of the process. What is your responsibility in role in this? It doesn't include any way of assessing distress or how to manage distress. And it assumes a degree of communication expertise. And when I looked at the list, particularly of the other specialty areas, I wondered whether we could assume that some of those practitioners would have the level of communication expertise expected for some very, very sensitive conversations when it's not part of their everyday work. Alluding back to, I guess, some of the private activity in particular, and looking at the demographics of a population, do we need to think about whether voluntary assisted dying activity will be even across local health networks, or will there be some local health networks that will have, because of the population they're serving, have a larger activity level than others? We don't know whether there will be a need for beds in the acute system. If so, where will they be and how will they be funded? And I took some notes of a workshop I went to earlier in the year when it was mentioned that some of the voluntary assisted dying in Victoria was happening in the hospital system. I took notes about why. Why were people coming into hospital for this when actually you don't really need to be in hospital to self-administer a medication? And the reasons that were put forward were that the patient was already there. So they decided while they were there that this was the right time. Another reason was that it would protect their family from having to witness this in the home setting. And the third reason that was put up was that there was some family discord, and that the person needed to be somewhere out of the home to enact voluntary assisted dying. So there is the potential that we will need some beds. If so, where would they be? How will they be funded? Is there an expectation, for example, that they're funded out of normal activity? Because I can't see that happening. And do we anticipate a greater demand for specialist palliative care services? And certainly within our legislation, there is a requirement for the minister to report to the Parliament about palliative care funding on a regular basis to show that it hasn't decreased, but there's no recognition that it may actually need to increase. The legislation talks about it not decreasing. When the discussion first happened in Victoria about the introduction of VAD, there was comment that there was a considerable concern that there would be more referrals to palliative care and more demand for palliative care services. And there was a support from the government at that time for that to occur. I'm not exactly sure that, other than through projects and things, that there's been a sustainable increase in palliative care service resource. I also wondered, I don't think Victoria have support systems for individual providers, but there has been some feedback to say that this can be quite a difficult clinical activity to be involved with. And I just wondered about, in our implementation, whether we need to set up a support system for individual doctors who agree to be part of this. And I also think the portal, the way we run the portal, is going to be very, very important if that's the way we decide to go. Kate, I'm going to hand over to you.
Thank you, Chris, and thank you, everybody. Look, I'm reporting to you really from where we're up to with voluntary assisted dying within the department at the moment. And I suppose what we thought was really important for people to understand is how the governance is starting to shape out and how it's starting to look. And as you would be aware, we do have palliative care as a specialty. We also have a palliative care clinical network, and that has within it some key advisory groups. You know, we do look at our Aboriginal Torres Strait Islander groups. Bereavement care is a big area of interest that we have in palliative care, and it is something that needs to be considered for voluntary assisted dying. And at the moment, I think most legislations are still pretty silent on bereavement care for those after a voluntary assisted death. There's an aged care advisory group, and there's a data group. There's also a pharmacy group that sit under the clinical network. Now, these are palliative care specific, and I suppose what I'm clear and what I want to make really clear to everybody listening is that the palliative care is not voluntary assisted dying, and that the voluntary assisted dying has to stand in its own space. It will also have to have its own funding, and the working groups will be working around the implications of implementing the Voluntary Assisted Dying Act as it is. The other area that you'll see that sits in the end of life care program governance is advanced care planning. And so we do have we've been working very hard in the department on addressing the recommendations that came out of the Lacey review for the Advanced Care Directives Act. And so that work is being progressed as we speak. But we recognise that advanced care planning is a key component of end-of-life care. And again, you know, it will have a role to play, although stating that you want voluntary assisted dying in an advanced care directive is not on the cards at this stage. So you have to make that, as Christine already identified, you have to make that request. It has to be enduring. It has to be on more than one occasion, so it won't stand as a component of an advanced care directive. So that brings me to voluntary assisted dying, which is a very new body of work. And as you know, it was only endorsed in June of this year. We're aiming for a time frame of about, or it'd be a little bit longer than 18 months, largely because South Australia has an election next year. And that in and of itself causes all sorts of challenges in that the department goes into caretaker mode, which means a lot of decisions cannot be made while we're in caretaker mode. So that actually will delay things. And certainly advice from WA to us was, if you can avoid implementing voluntary assisted dying and having an election at the same time, that would be highly recommended, because they too had an election in the middle of their act. So I suspect that they didn't avoid it, we won't avoid it, but it will have an impact on timeframe. So we are aiming for March 2023, but that is not confirmed. It's just an aim at this stage, and it could be brought forward because Queensland, who have just gone with approval for their act, are planning to enact their bill on the 1st of January 2023. So we're yet to see what the date will be. But talking down to the detail, as you can see in the governance slide, there is the existing governance within the Department of Health. So the group that I sit with, we have an executive director who reports up to the deputy chief executive, who then reports to the chief executive, and ultimately everyone reports to the minister. But sitting adjacent to the Minister of Health and Wellbeing is the Voluntary Assisted Dying Review Board, and that will be a ministerially appointed board. We're not sure the numbers yet at this stage. WA have got 5 board members for their board. Victoria have got 13. But Victoria say that they had no say in their numbers. That was what was appointed. Queensland's legislation talks about having a minimum of 5, but no more than 9. We've done a skills matrix for the board, and we've landed on 8 members, which we think is probably about right. So again, this is all in the planning. What's just been put forward at the moment is the minister is about to send out letters to start the implementation work that needs to be done. So he will invite members of the community to participate in the implementation task force. And so that task force, secretariat support from the department, and they will oversee a whole lot of working groups. So we will have a care pathway working group, consumer information, clinical guidelines, education and training, and the medication protocol. They're all very big pieces of work. They all require a strong level of communication support sitting underneath them so that the messaging to the community is very and consistent. The clinical guidelines will be for the clinicians and their roles within hospitals. Education and training, we're the only country that has mandated education and training for voluntary assisted dying. So there's a lot of interest in this space from a research point of view, particularly Queensland University of Technology, who have the contract for providing the education in both Victoria and Western Australia. So they are actually looking, I think, at some of the safeguards of having the clinical workforce educated in the legal requirements and the legislation. So it's not about how you go about managing voluntary assisted dying. It's about making sure that clinicians fully understand their legal position in the role that they will play. The medication protocol has huge, again, considerations that sit around it. The substance that we will be looking at is not a legal substance, and so we'll have to go through the TGA in Canberra to get exclusions to have that come into the state. Victoria actually bought in the intravenous version and then had to go to a compounding pharmacy to turn it into an oral formulation. And so I imagine that there'll be those types of considerations that we have to work with. So they are the work groups. They are really, they're going to be very involved. They're going to be working very hard in the next 12 to 18 months in terms of making sure that the system is prepared and ready for voluntary assisted dying. And we'll move to the next slide.
Sorry, Kate, can I just ask one question? Sorry to interrupt.
That's okay.
The review board, you alluded to the fact that they're different in different states, and that you think about, 8 people might be the right configuration. My understanding is that in Victoria, it's largely clinicians, that the chair who has just resigned was a retired magistrate. Correct. And that they have one other legal person on their board. Is our board likely to be clinician based, or will
it will be a mix, and there is a strong reliance that we have suitably qualified consumers on the board, so they don't want a domination of SA Health staff. But there also is a requirement for law and ethics to be represented on the board. So I think by virtue of that, we will see a balancing out in that space. We're working through the delegations of powers, and Victoria's only just starting to talk about subcommittees for their board. So they have not delegated any of their powers from their board to date. And so again, I think Victoria are the test case, and we are watching and learning from their experience as to how it's all working. But I think that they've needed their board to be tight and contain all the information and all the decision making, because everybody else in the country is watching them. But if they do start to delegate to subcommittees, then of course we'll be very interested to see in what areas that tends to happen. So the next slide again is just that overarching work stream governance, and I've already started to speak to that, but what I haven't spoken to is the three boxes below, which has got Secretariat next to it. So it talks about the Vad Regulations, Information Technology Systems, and the Vad Review Board establishment. So in Victoria, they actually established their review board 12 months before they enacted their legislation. And they did that because they were the first cab off the rank, and they needed to make sure that everybody was on the journey. WA only got their review board came into operation when their legislation was enacted. So they didn't bring them on 12 months earlier. They had their implementation work group instead, managing all the work, and then kind of like handing the baton over to their VAD review board once they were satisfied that everything was established and ready to go. So the VAD review board will be ministerially appointed, and their term is likely to be 3 years. It could be, you know, that an individual would leave for other reasons, but members will have the opportunity to be reappointed. And so there's really tight requirements around who can be a member of that board, but the skills matrix is essential to making sure we've got the right skills reflected on the board, and also the usual criminal history checks that we have just in the general employment play out for board membership as well. The information technology systems is really probably the linchpin that holds all of this together. So you've heard Christine mention the fact of the portal being really a key role for the clinicians in Victoria. And it has to be user-friendly. They have to be able to get the information that they need. The timeframes to turn information around is not great. Victoria have said in general, it takes between 4 to 6 weeks from the first request to the final act of assisted dying to take place, but the minimum timeframe is 9 days. So I think what you'll find is that the requirements around how soon documents have to be uploaded into the portal, having any glitches that happen at that point underpins the importance of why the technology needs to be really sound and really solid. So from a South Australian point of view, we have had conversations with our counterparts in the other states. WA had completely built theirs from the ground up, and they are just in the process of talking through the legal options of potentially commercializing their product. So there is a slight opportunity that might become available as something that we can buy off the shelf already made, purpose-built for voluntary assisted dying. But it's also possible that we have to do that level of work ourselves because of security, firewalls, the other things that we have in this state. So there's no promises there, but it is identified as a very significant piece of work that will need to be undertaken sooner rather than later, because actually if that's not ready, it's going to really compromise our ability for the day that we actually enact our legislation. And then the VAD regulations, look, they've been drafted for now, as in our Premier made an announcement the regulations would be available by Christmas. And so the regulations have gone through a targeted consultation phase, and we're just in the process of providing that feedback back to the Minister, and that they will have those in draft form. The regulations are not locked in though, so what it does mean that in the next couple of months, if we, through the task force working group, if we start to find that there's other material information that really needs to be reflected in the regulations, we can actually make an approach back to get that included. So the initial regulations are really drafted very closely again to the Victorian regulations, but as we progress the work, if we need to change that, we can do that. So that's where things are at for us at the moment. We've got a lot of work on at the moment. We've got a cabinet submission being prepared so that we can get dedicated funding for voluntary assisted dying to actually follow through with all the requirements that need to be met. And I would expect that we'll start to see some formal communication about where South Australia is up to coming out in the very near future. So once the Minister has finalised the implementation task force requirements, I think we could start to see that coming out, and that the community will be then informed as to where things are up to. So that's really it from me. I know that Chris and myself are both happy to take questions. So I will stop.
I'd just like to say one more thing, Kate, or you might like to speak to this. If we're planning for, say, 1 to 2% of all South Australian deaths,
yeah,
what are the numbers? You know, if 1 to 2% of deaths are associated with a request for voluntary assisted dying, what kind of numbers are we looking at across the state?
Well, I think we had less than 14,000 deaths. It might have been 2017 or 18 when the last ABS numbers came out. And I think we worked it out. It was about somewhere between about 55 to maybe 110 requests for voluntary assisted dying. So we're not talking big numbers to start with. But as you have already indicated, in countries where it has become part of an end-of-life choice, I think over time it will be interesting to see how that progresses. While our legislation is as tight and conservative as it is, it will continue to keep the numbers, I think, at that level of 1 to 2%. And again, as you've identified, I think if we were to see slippage away from that and start to take prognosis out and put intolerable suffering as the overriding reason, I think we would start to see a change in numbers.
And so that what you're talking about is numbers of deaths, not requests. So requests could be more than that, are likely to be more than that.
Absolutely.
So we may follow through with a lot of the process. In fact, the numbers may be significantly more than that, but somewhere around 100 might actually follow through.
Yeah, correct. Yeah.
Kate and Chris, it's Peter. I'm going to stay with my video off just because of this very poor connection in Whyalla. So thank you very much for both of you for your time and effort in trying to distill such a complex topic into 60 minutes. So we're almost out of time. So firstly, thank you very much. There will be able to send in other questions via the chat box, and Chris and Kate will be able to answer those. But one that's come in is about early onset dementia, and will they be able to access voluntary assisted dying when they no longer have any, are able to function? So the question really, to summarise, can someone with dementia make a pre-existing statement in an advanced care directive?
There's no provision for that at this time. They have to have decision-making capacity. That's an absolute given. Their death has to be expected within 6 months. So that's going to rule the majority of people with dementia out. So at this point in time, no, they can't. And, you know, that will require legislation change.
Yes. And people can write in their advanced care directive that they would, that they believe that this would work for them. We can't enact it though. So, but what it might do, if a person were to write that they would want voluntary assisted dying if they could access it, it might inform some of the other care decisions and the conversations that happen along the way with those people who speak on their behalf. So, for example, if they said something like, if I couldn't recognise my family, I would want to access voluntary assisted dying. They clearly can't do that because they no longer have decision-making capacity. But it may be that the family then say, well, you know, we speak on behalf, we're the substitute decision makers for this person, and we think that we don't want this pneumonia treated. So it would inform conversation, even if it can't directly be seen as a request.
I would agree with that, and I think that's where we have to do so much work on advanced care planning as well.
Exactly.
To get that in place. The other great source of information, which is free to access, and Kate has alluded to Queensland University of Technology, they have an end-of-life education program, which you can register for and go through a whole series of topics, including voluntary assisted dying, but end-of-life law for the healthcare professions, from nursing to allied health to doctors. And it's a fabulous site, and it's free to access for that. Unfortunately, we are out of time. I thank both Chris and Kate for their presentation today. Nicole and Jody, as always, in the back room of the Rural Support Service, thank you for organising, coordinating, taking all the bookings, sending out all the links. This is a process that takes a lot of your time, so I thank you both for that. We have one more session booked in for later in the year, which is allied health specific, looking at palliative care and occupational therapy and allied health role. And Deirdre Morgan will be running that from Flinders University, particularly looking at case-based management and access. So I welcome you all to join us with that. Always look at this online, share this information with your colleagues. This starts a conversation around the tea room, around the dinner table. How are we going to do this, particularly with reference to our large rural network that we help to look after? So stay safe and well, everyone. Chris and Kate, thank you very much. Nicole, thank you.
Thank you for having us.
Take care, everyone. Bye-bye.